Welcome to Mid One Page. My name is Benjamin, and today I'm going to be talking about head injury. So we're going to start with the biomechanics and pathophysiology of head injury. So head injury is basically a trauma to the head, and most of the time the mechanism of injury involves probably a direct blow to the head. That's if someone is hit on the head by something, and that's most commonly going to cause skull fractures, epidural hematomas, as well as confirmed contusions. But don't worry, we're going to discuss these things in detail. You're going to understand each of them. Then we have acceleration deceleration injuries. This one is when someone is moving probably at a high speed and they come to a sudden stop. That is if they knock something most of the time. And this is going to cause most of the cranial, what we call subdural hematomas, as well as diffuse axonal injuries. Then we have rotational forces. Rotational forces are very, very severe on the head because the two hemispheres move at different speeds, and when they move at different speeds or are rotating at different speeds, you're going to end up with shearing of the vessels that are connecting the two hemispheres. That is the corpus callosum, and that is going to cause a diffuse axonal injury. Then we have blast injuries, most probably in war zones where we can have barotrauma due to pressure, acceleration, penetrating debris. So when we look at brain injury, we have the primary brain injury, and this is the one brain injury that we cannot reverse. Most of the time, it's due to the contact, where we have now the transmission of the force from the external factor or the environment, or if someone falls down and that force is transmitted onto the neurons of the brain, that is going to cause the primary head injury. And for that, most of the time, we can't do anything about it, cannot reverse it. So what happens is that when someone is hit or when someone comes to knock something, we may have things like lacerations on the brain. Probably if someone was stabbed with a knife on the head or a sharp object, we can have depressed fractures, we can have contusions. When we look at contusions, these are basically bruises on the head, on the brain. So the brain contusion can be on the side where the head was hit, or on the side where on the opposite side. So this happens when the brain is hit, when the head is hit on one side, the brain accelerates and hits itself on the other side of the skull, and this is the contra-coup. So we have the coup and contra-coup contusions or injuries to the brain. Then we have the epidural hematomas, where we have blood collecting between the skull and the dura mater, and the subdural hematoma, where we have blood collecting between the arachnoid mater and the dura mater. Then we have inertia. So inertia is when we have movement and then things come to an abrupt stop. So when things come to an abrupt stop, for example, if you are moving while holding a bar, while holding water in a basin, and you come to a sudden stop, the water will continue moving. Something that happens when a car suddenly breaks down while on high speed, you find yourself moving forward. So that's inertia. So it happens also in the brain when we have this lesion, when we have this acceleration and sudden deceleration. That causes the brain to continue moving, and sometimes the brain moves at different speeds, and that causes shearing of axons or tearing of axons most of the time at the corpus callosum in the brainstem, and this leads to diffuse axonal injuries. And most of the time, the prognosis for these kinds of injuries is really, really not good. Then we have the secondary brain injury, and this one is the one that we try to prevent when we're in the emergency department. It's going to be caused by things like hypoxia, hypotension, hypercarbia, cerebral edema, increased intracranial pressure, as well as decreased cerebral perfusion pressure. So as you fight to decrease your intracranial pressure, you have to always keep in mind that if you decrease the blood pressure too low, you're going to have a decreased cerebral perfusion pressure, because of this equation right here, that cerebral perfusion pressure is equivalent to the mean arterial pressure minus the ICP. So if the ICP or the intracranial pressure goes up, cerebral perfusion is compromised. Also, if the mean arterial pressure goes down, still cerebral perfusion is going to be compromised. Then you have microvascular injury, whereby we can have maybe shearing or tearing of blood vessels, and when we have reduced blood flow to the head, we can have neuroinflammation that can be caused by a lot of things. Then excitotoxicity, where we have release of glutamate, and most of the time when we have a lot of glutamate within the neurons, we end up with having seizures or convulsions. So we want to always target a cerebral perfusion pressure of around 60 to 70 millimeters of mercury. So we go to the classification of head injury. we have the classification. The first one is by the GCS, and we have the mild, the moderate, and the severe. The mild head injury is when we have a GCS of 13 to 15. The moderate head injury is when we have 9 to 12, and less than 8 is considered severe head injury or coma. And most of the time when a patient has a GCS of 8, intubation is done because we assume that this patient cannot really protect their air. Then we can also classify according to anatomy, where we can say things like scalp injuries. If we have the scalp affected, that can be abrasions, lacerations, or degloving. We can have skull fractures. Those can be linear, depressed, or comminuted. We can have open vascular fractures, where we have communication of the brain or not. Then we can have basilar fractures. Those are fractures that happen to the base of the skull, and that is the anterior, middle, and posterior cranial fossas. Then I can have intracranial injuries. And when you look at intracranial injury, you group them into two. Some are intraaxial, some are extraaxial. Extraaxial are outside the brain parenchyma. That is epidural hematomas, subdural hematomas, and traumatic subarachnoid hemorrhage, as well as intraventricular hemorrhage. Then intraaxial are the ones that are happening in the brain parenchyma. That is contusions, intracerebral hemorrhage, diffuse axonal injury, as well as concussion. So most of the time when you're in the ER, the patient will come with the following clinical features, and these are things that are going to make you suspect that probably this patient has had an head injury. If we have symptoms like a loss of consciousness, they have things like confusion, they have amnesia, they have headache, vomiting, seizures, focal deficits, CSF leak. Most of the time, these are the symptoms that you may have. Then the signs, you may have things like altered GCS, that's the Glasgow Coma scale, pupillary changes, all things like anisocoria, where the pupils are not equal, pupils are not responding to light, people are dilated. You can have hemiparesis, where they don't feel part of their body. We can have posturing depending at the level of the lesion. If a lesion is cutting off the cerebral cortex, we can have decerebration, and the patient will have a different presentation from if the lesion is cutting off at the level of the brainstem or the cerebellum. And we shall have things like extended posture or a flex posture, depending on where we have those things occurring. Then we have the Cushing's triad, where the patient has widened pulse pressure, bradycardia, chest stops breathing, and this is a sign of increased intracranial pressure. Then we have basoskull fractures, and most of the time we see things like the Bartos sign, which is bleeding behind the ear. We have the raccoon eyes, which is ecchymosis around the eyes. We have hemogympanum, which is blood from the ears. We have CSF rhinorrhea, that's a CSF from the nose, CSF otorrhea, CSF from the ears, as well as cranial nerve 7 at cranial nerve 8 pulse. These are signs of basoskull fractures. Then we can also have herniation, and herniation is one of the outcomes of increased intracranial pressure. So when the brain is being pressed on, it is going to push, it's going to, let me say it's being pressed from one side, it's going to move, and when it moves, it is going to enter these different openings within the skull. So the first kind of herniation we have is a ankle herniation. So we have the tentorium cerebelli, which is the membrane that separates the cerebral cortexes up and the cerebellum. So within this tentorium is a notch, a hole. So most of the time when the lobes are being pushed from the side, the part of the temporal lobe called the uncus finds its way into that notch downwards. And then as it goes downwards, it's going to press on the third nerve, which escapes through the ankle notch to come and move along the tentorium and go supply the eye on that same side. So when that happens, you shall have an ipsilateral pupil on that side blown, which means it's not going to react to light. And then we have contralateral weakness because for the motor neurons, they decassate at the cerebelli. Then we have central herniation, and this one is when we have herniation of the central brain, the diencephalon. That is where we have the thalamus, subthalamus, things like that. And the thalamus and subthalamus, as well as they're important in the RAS, in the registrar activating system and things like that. So when we have pressure on them, we shall have things like decreasing level of consciousness and mid-position pupils. Mid-position pupils Then tonsillar herniation is when you have the cerebellar tonsils being pushed through the foramen magnum, and this is where we have the respiratory centers as well as the cardiac centers are known to. First on these centers, we're going to have things like bradycardia and apnea, or the irregular breathing seen in Cushing's. So when you do examination, this is according to the ATLS, the primary survey. You want to do airway as well as spine immobilization. You avoid things like the chin lift maneuver. You want to just do the jaw thrusts or put a collar to support the head. In children, you have to be very careful because the head is bigger. Then, and most of the time, it can easily obstruct the air. Then you want to check the breathing, the circulation, the disability by checking the CS pupils or lateralizing signs. So these are signs of focal neurological deficits, which you can see. And there are many of them, and it would be good if you check them out. I will not cover them in this video. Then you have exposure, where you want to check out the whole patient. You want to see, is the patient having any other bleeding? Do we have anything else? And with this, you have to make sure you don't expose the patient to hypothermia, because we saw it's another cause of secondary head injury. Then during the secondary survey, you can do a full neurological exam, you can do the brain nerves, you can do the motor and sensory examination. You can check for signs of intoxication, because many people get accidents while intoxicated and they sustain head injury. Then you want to check the ear and nose for CSF leak. Then when you do the investigations, you want to do your laboratory investigations as CBC electrolytes, coagulation profile, arterial blood gases, glucose, tox screen. You want to do the imaging, where the CT is the first line, and we have indications for doing CT in head injury. For example, when someone has a GCS less than 15 after 2 hours of admission, you want to do the CT. If you have a suspected skull fracture, a basal skull fracture sign is warranted to do a CT. If you have repeated vomiting at least 2 times, you want to do a CT. If your age is greater than 65, also if they are young, the young children, so the extremes of ages, most of the time you want to do a CT. If the patient has a seizure, you want to do a CT. History of a coagulopathy, these people are very prone to bleeding, you want to do a CT. If there was a dangerous mechanism, someone has maybe in a very bad game or a traumatic accident, you want to actually consider the mechanism and do a CT. If there is a focal deficit, you want to do a CT. Loss of consciousness greater than 5 minutes, you want to do a CT. And if they have severe headache, you want to do a CT. And most of the time when you do the CT, we have the signs that we see and give us an image or what you think can happen. For example, when someone has an epidural haematoma, most of the time they are going to have a biconvex hyperdense area, and this does not cross suture lines, and this is because the dura mater attaches around the suture line. So as the dura reaches the suture lines, it attaches within those suture lines tightly, so the blood can only collect within that area of the sutures. It will not cross suture lines. While when we go to the subdural hemorrhage, it is precenteric. It's going to cross the sutures, but it does not cross the midline, and that is because we have the falx cerebelli, and that is separating the 2 hemispheres, and it's going to look like a banana. Some call it the banana shape on the CT. That is a subdural hemorrhage. Then we have contusions. Well, basically we have some small intraparenchymal bleed, some more, and mostly at the time they are going to be at the frontal or the temporal regions. Then we have the dramatic subarachnoid hemorrhage. This is because we have another subarachnoid hemorrhage which could be gestal to an aneurysm. And most of this time, the blood is going to collect within the sulci. These are the depressions on the brain. So we have the gyrus and the sulci. So the brain is going to collect within the sulci or the system, and they are going to appear as hyperdense, and that is the traumatic subarachnoid hemorrhage. Then the diffuse axonal injury, most of the time the CT is going to be normal, but the MRI is what will show maybe some lesions occurring on the corpus callosum as well as on the brain stem. Then others want to do a CT of the cervical spine and also a FAST, which is the focused abdominal sonography in trauma. You want to look for bleeding within the trauma, within the abdomen, because still this patient would die from that. So when you look at some of these things, how we intervene when we have specific injuries, whenever we have skull fractures, most of the time we do not operate unless the fracture is greater than 1 centimeter in deep, if it's open or contaminated, if we have CSF leak, or if we have an underlying haematoma. Then when you have basilar skull fracture, it's important to avoid putting NG tubes, because imagine someone has a broken ethmoid and then you or a broken cubiform plate, and then you insert an NG tube, it could easily get into the brain. And sometimes you want to test for CSF if there is blood coming from these orifices, maybe the nose, maybe the ears. And most of the time, the laboratory test is beta-2 transferrin. You collect this blood and check for beta-2 transferrin, which is specific for CSA. But then we also have a halo test, which you can do at the bedside, where you pour blood on a paper, probably like a filter paper or something like that, or on gauze. And we shall have a ring of blood forming, as well as another ring around it. And the ring around it is going to be colorless or whitish in color, and that is going to show that is CSF. Then you want to manage this CSF looks conservatively for some time, and after around 14 days, where we expect the bone has formed colors. If it does not stop, then you want to at least do things like the lumbar drain, or ventricular drain, where you reduce on the amount of CSF, and when you reduce the amount of CSF, you're giving chance for this bone to heal with less pressure on it. Then we have the epidural hematoma, and we said the epidural hematoma is going to come when we have rupture of the middle meningeal artery. And when you have the middle meningeal artery bleeding, so it's an arterial bleed, the patient is going to have a lucid interval. So there are 3 stages of this epidural hematoma. The first time, when the patient is hit at the pterion, that is the most common place where we have epidural hematomas, where blows to the pterion are going to cause rupture of this middle meningeal artery. The concussive symptoms are going to take them out. So they're going to faint, they're going to lose consciousness, and then they regain that consciousness. Now they're in that interval where the blood is accumulating for a stage. As the blood accumulates, they are normal, they are talking, and then all of a sudden they worsen because of that rising intracranial pressure. They lose consciousness again. So if they have a volume of greater than 30 mils within that subarachnoid hemorrhage, you may actually need now to open up and remove that blood before you have a herniation happening. And sometimes you even have to achieve hemostasis, because this is an arterial bleed. Sometimes it doesn't stop on its own. If the thickness is greater than 15 millimeters, you want to operate. If the midline shift is greater than 5 millimeters, still you want to operate. And if we have a deteriorating GCS, comes a GCS that is probably like at 13, 14, 15, when they are deteriorating downwards, you want to do surgery. Then if the GCS is less than 9 at the time of admission, still you want to do a craniotomy. So we do an emergency craniotomy, and for small lesions, sometimes you can observe and do a repeat CT to see if it's expanding. Then we have the acute subdural hematoma, and this one is going to occur when we have the bridging vessels. The bridging vessels are bridging between the dura and the arachnoid matter. So if we have maybe a dissection and a shearing of those vessels and the break, that is going to collect within that area, which is called the subdural space. And when blood collects there, most of the time, because of the size of that space, a lot of blood is going to go into that area. Most of the time, it's going to have a high mortality. So if we have a thickness of greater than 10 millimeters or greater than a shift of greater than 5 millimeters with this subdural hematoma, most of the time you want to do surgery. And if the GCS drops, or you have pupils being asymmetrical because of that ankle herniation, then you also want to do surgery. Then we want to do a craniotomy as well as an evacuation, where you open up the skull and remove this hematoma. Most of the time it would have clotted. As so, it's important to note basically here that epidural hematomas are coming from a middle meningeal artery, arterial bleeding, while subdural hematomas are coming from veins, that is a bridging veins. Then sometimes we have a chronic subdural hematoma that is going to occur in the elderly, people on anticoagulants, and well as alcoholics. So the alcoholics and elderly have brain atrophy. So most times the brain is small and it moves within the head or the cavity. So the chances of those bridging veins breaking are very easy. Then anticoagulants, these patients easily bleed. So even when they start having a small bleed, it can worsen and they end up having a chronic subdural hematoma. So most of the time they have a progressive headache, change in behavior, seizures. Most of the time you can just evacuate this subdural hematoma with holes. Then we have the contusions. Contusions also occur in the frontal temporal area, And when you have contusions, which is like a bruise, having to have swelling, the swelling peaks on that too. And most of the time we treat it as ICP, is intracranial increased intracranial pressure protocol, and we only operate if there is mass effect or shift, that is midline shift or things like that. Then we have the diffuse axonal injury, and this one is when someone gets immediate coma. And this one we said it comes from acceleration, deceleration injuries as well as rotational forces that made the two hemispheres of the brain to move at unequal speeds. When this occurs, we have lesions of the corpus callosum in the brain stem, and CT is often normal in diffuse axonal injury, while the MRI may show these lesions on the corpus callosum as well as the brain stem. Management is normally supportive, and we want to reduce the increase in intracranial pressure. Most of the time, this carries a poor prognosis. Then we have the concussion. So the concussion is a temporary neuronal dysfunction after non-penetrating head trauma. Someone bangs their head, and then maybe they get confused, they lose consciousness, or they forget, they get retrograde amnesia. So most of the time when you do a CT scan, it's going to be normal. There's not going to be any changes. But sometimes they have deficits that are minutes to hours, and the most common deficit is memory loss. So we have the Colorado grading. These are the grades of concussions, where we have grade 1 where someone just has confusion, grade 2 when they get amnesia, in grade 3 they either lose consciousness, then they're in grade 3 concussion. What happens is that after this hit the neurons have taken, there's brain hypermetabolism for about 1 week, and there's high vulnerability between those 1 to 2 weeks that follow. And then someone gets head injury after that, they have what we call the second impact syndrome. And this is commonly seen in athletes. Someone maybe gets hit in a match, they fall down, they get confused for a moment or two, they come back and play again, they get hit the second time, and this time they get a more severe injury. This is the second impact syndrome. And there's a risk of persistent headaches or memory issues after someone has had a concussion. This is what they call a post-concussive syndrome. Then we have penetrating head injuries. This occurs when you have things like missiles, that's bullets or shrapnel, and non-missile things like knives or ice picks. And most of the time you want to do an imaging, like a skull X-ray plus CT to define the trajectory or the fragments, and geography if you suspect that this thing could have passed in the path of major arteries or the venous sinuses within the brain. And most of the time the surgery is done if we have protruding objects that are protruding through the skull, and we perform what we call controlled removal, debridement, irrigation, hemostasis, and closure. And deep fragments most of the time are going to be left in place, because as you go in to remove these fragments, they are deep within the brain. You're going to have what we call secondary injury. You're going to cause injury to the brain yourself. Then we can do medical therapy, where we treat with both spectrum antibiotics to try and prevent this meningitis from coming in. Then you want to do tetanus prophylaxis. Then you want to give a 70-hour seizure prophylaxis, that is with phenytoin. Then you want to control increasing blood pressure as needed if it's there. So for when we have high velocity injuries like bullets or gunshot wounds to the head, for them they have a shockwave whereby when they enter the brain, they transmit the force, and they transmit the force on the brain. You have a cavity developing, so you have massive tissue destruction just even after, and not just where the bullet left, but it forms a very big cavity and they have a high mortality. So someone may ask, why is that when someone has a penetrating injury, they are not dying? That is because we have fatal patterns. So if we have a projectile that is crossing both hemispheres or traversing ventricles, most of the time that is when this patient is going to die. And the complications with penetrating head injury, sometimes there's hemorrhage, vascular injury, infections, seizures, CSF leak, as well as chronic deficits. So in emergency head injury in general, we have the hospital management and the emergency department management. The hospital, you want to avoid hypoxia or hypotension, you want to immobilize the cervical spine, as well as give oxygen. Then in the emergency department, you want to do the airway, breathing, circulation, disability, as well as exposure. You want to intubate if the GCS is less than 8. You want to make sure the pressures of oxygen are greater than 60 and avoid hyperventilating that patient unless they're having herniation, because when you hyperventilate this patient, you are going to constrict the cerebral blood vessels, and when they constrict, you're going to reduce the cerebral perfusion, and remember, decreased cerebral perfusion pressure is another cause of secondary brain injury. Then you want to maintain the systolic blood pressure less than 100. greater than 100 to 110, that is to avoid hypotension. So you don't want to make it go higher than that, but you don't want it below 100. Then disability, you want to check the GCS, the pupils, you want to give glucose if they are hypoglycemic, you want to treat seizures. Then exposure, you want to avoid, do a full exam, but avoiding hypothermia. Then we can have the ICP management. So ICP is going to be managed in tiers, depending. First of all, we can do the heavy elevation at 30%. You want to maintain a neutral neck, so the neck should not be hyperextended or flexed. You want to give analgesia plus sedation. You want to maintain pneumoxia and hypoxia. Then you can give hospitotherapy. That is mannitol. That is 1 gram per kg or hypertonic saline. Then you want to control the temperature and homothermia. This is very important. So you're going to try these ones. If they are not working or you feel you need to go ahead, there is a tier 2 where you can do hyperventilation temporarily, let's say with the ventilator, and this is going to remove carbon dioxide from the system, so your blood vessels are going to constrict, and then you will have decreased cerebral perfusion pressure, which will reduce on the intracranial pressure. Then you can do ventricular drainage where you set an external ventricular drain to remove CSF. Then you can do neuromuscular blockade or paralysis or relaxation of the muscles of the patient. This is going to also cause reduced intracranial pressure. Then tier 3 is when this fails, you can induce a barbiturate coma with your penton. You can do therapeutic hypothermia, and this is for selected causes. And you can do a decompressive craniotomy where you cut off part of the skull when you have refractory intracranial pressure. And then when someone has a GCS less than 10, a diffuse fracture, contusions, subdural hemorrhage, epidural hematoma, the physical injury, you want to prevent seizures in these patients. So you are going to use phenytoin, or if you are short-term, and we are going to give that for a week, and that is what we call the early onset seizures. But sometimes we have the post-traumatic epilepsy. Most of the time we don't do prophylaxis for that because there has not been any evidence that has shown that it prevents it. Then complications, early, sometimes we get hypoxia, hypotension, seizures, coagulopathy, CSF leak, the meningitis, acute hydrocephalus when you block the ventricles, and then herniation. Then late, epilepsy, chronic headache, cognitive issues can occur, pituitary dysfunction can occur, chronic subdural hemorrhage, post-concussion syndrome, and sometimes you have the Cushing's ulcer. So to end this video, it's important that you always know the coding neurotrophic gene, which says that the skull is a liquid valve that contains the brain, the blood, and the CSF. And those are the percentages: brain 80%, blood 10%, CSF 10%. And the total volume is always constant. So what happens is that we have compensation. Whenever the CSF shifts, venous blood out. The compensation is that we have CSF shifting, venous blood outflow, then we have brain compression. So when ICP rises, since we have a small volume in the skull that is redundant, small volumes are going to be tolerated initially. But when we reach the threshold, you're going to have decompensation and exponential ICP increase, and then we have herniation of the brain. That is why you see that lucid interval occurring in patients with subdural haematoma, with the epidural hematoma. They are taken out by the concussion, they lose consciousness, they wake up. In that period, the body compensates for the small rise in intracranial pressure, but as it reaches the point where we can no longer compensate, then the patient produces consciousness again, and then from that side, it's a down slope and need to intervene. So we have come to the end of this video. I hope you've learned a lot about head injury. Don't forget to subscribe to the channel if you're not subscribed. Leave a like. My name is Benjamin. Have a nice day.